It's a great pleasure and honor to be here with all of you. I know that there's an extraordinary group of people in the room there in Salzburg. Maria Luisa, my new colleague from the World Bank, and also others, and my former colleagues also from Dartmouth College. What you've all discovered there is that Dartmouth is an absolute jewel in the American higher education world, because at Dartmouth they've taken more seriously than in fact any other university I know in the world the problem of tackling healthcare service delivery. I've been saying for years that this is the great neglected area of healthcare. And as my good friend Al Mali says all the time, healthcare in almost every part of the world is working under the fantasy that if you have great science and put it in the hands of trustworthy individuals, you're done with the problem of healthcare. And of course, what we know is that that's where the problem of healthcare actually starts. And we've not taken seriously the enormous complexity of delivery in every country in the world. There is no country in the world, whether the richest countries in the world or the poorest countries in the world, that don't have a problem of how to use their resources for healthcare to actually produce a healthy population. We know how to build hospitals. We know how to do procedures, but we actually are very bad at having the best health outcomes. And what we also know is that the richest countries sometimes do it the worst of all. So you're there talking about a critical issue. And it's an issue around which the World Bank has enormous interest and enormous stake. You know, we are in an organization that I have come to learn is just full of fantastic practitioners. You have them in the room with you today. I have here next to me people that I have called master clinicians of development. And the reason I call them that is because what they do every single day is to help countries and projects solve the problems that are in front of them. You know, there's a tremendous difference between people who've got the extraordinary training that people like Tamar and Sanjay, Maria Luisa have, who sit in universities and write papers, versus people who've done all the academic work and then every single day solve problems that are facing them. I equate it to basic science researchers and clinicians who every day have the patient in front of them. At the World Bank, in a very real sense, every day we have the patient in front of us. We have clients who are saying, we want to build roads, we want to build healthcare systems, we want to boost prosperity by stimulating growth in the private sector. And we have to bring to the table every day solutions, implementation support in ways that actually make a difference at the country level. So this group of people we feel very close to, the people that are in the room in Salzburg, because we feel like we're getting at the exact same issues. We fully embrace the rights-based approach to healthcare. In fact, we've gone very far in that direction. And through many of our conditional cash transfer programs, we actually pay people to get healthcare. We give them money on the condition that they will get the kind of health care for their children and for themselves that we know makes a difference in economic development. So we have some examples that we might bring up later in the conversation. But more than anything else, I just want you all to understand and feel how much we're with you. I think this is one example where the extraordinary work done by the Dartmouth Center for Healthcare Delivery Science is aligning perfectly with the kind of work that we've done at the World Bank for years. This is the great unknown truth of the World Bank, that we are not an organization that sits around and puts out reports. Our reports are extremely important, they're very influential, and that's how people know us. But what we actually do every single day is solve problems for clients on behalf of the beneficiaries, the poorest people in the world. And I'm extremely proud to be leading this organization, and I'm even happier that my previous organization and the organization that I'm part of now can come together around this important issue. So let me leave it at that. More than anything else, I want to hear what you've been working on, and then allow some time for Tamar and Sanjay and I to respond. Thank you.
Thank you very much, President Kim. And since you're so eager to listen to what they have done, and I'm very eager to let them talk and show their presentations, I would like to just say that you are going to hear now 4 very short presentations, and I'm going to ask one fantastic facilitators to ring a bell when they complete their 2 minutes of explaining to you very eloquently what they wanted to do. The first presentation, it's on Egypt, is the Egyptian Healthcare Governance Initiative, and Dr. Maha El-Rabat is going to present. Maha?
Well, good morning to you all. I'm Maha El-Rabat, Professor of Public Health, Cairo University, and I'm representing the Egyptian delegation in the Salzburg Global Seminar number 500, talking about the Egyptian Governance Initiative. I'll mainly talk about the problems and the proposed solutions, and I won't take much time. So the problem is mainly rotating about the failings in the health system to provide efficient, equitable, inclusive access to quality of healthcare services to all. All of this are due to the governance deficit, combined with the lack of the shared decision-making among the governmental and non-governmental stakeholders. So overall, there is this overwhelming dissatisfaction among the population about the quality and accessibility to services. We're proposing to build a robust multi-stakeholder coalition to proactively engage in collaborative efforts to strengthen the governance in the health system. So we will be engaging the multi-stakeholders from the Ministries of Health, Ministries of Finance, the private sector, the civil societies, the service providers in the private and the public sectors, pharmaceuticals, all of these multi-stakeholders, academia and others, and activities should extend or should be covered within the next 3 years, hopefully. By doing this, we are improving the overall transformational change and making a new social contract that reflects the aspirations of the Egyptian population to the road to health. Thank you.
Thank you very much, Maha. Thank you very much. As you can see, many of the groups here identify, as you were saying as well, that some of the issues that the health systems in our countries have, it's problems of governance, problems of transparency and accountability, and they are looking for an approach to use multiple stakeholders to address these issues to see if that way health systems can really help and support the improvement of health outcomes. Our second presentation is from Kenya, and it's a proposal called TikTok. And Ms. Anne Nyugu is going to present. Anne?
Mr. President, and your 2 vice presidents, all protocols observed. My name is Anne Njogu from Kenya, but I make this presentation on behalf of a multicultural and multi-diverse team with members including Iraqi from Georgia, Benedict from the UK, Siri from Norway, Claire from the UK, Majnu from USA, and Christine from the USA. The challenge that we are working on is the inherent tension in any society between the priorities and the rights of the individual and the priorities and rights of communities, and the need to create a healthy balance between these 2 polarities. We therefore call it the TikTok model, balancing tensions between individual collectives and a tool to improve outcomes across countries. Our approach to address this challenge is to develop a diagnostic tool that, 1, will allow the stakeholders in whatever context, whether in the developed or in the developing countries, to assess where the balance between the needs of the population and the needs of the individual exists in their own country. Secondly, we shall also set up teams to analyze and share the results with the stakeholders and facilitate discussion on the next few steps. We shall design and test this tool over the next 3 years in Kenya, in the USA, in Georgia, and in Peru. The 4 pilots shall include a range of using the methodology and indicators from which we shall be able to refine the process and indicators in order to support and promote fairness and consistency in accessing healthcare and services across all countries. What we need from you is the support to develop this tool, including the indicators and methodology, and to develop the pilot sites. Thank you very much.
Many thanks, Anne. Well, as you see, I mean, it's so difficult. You will imagine the model that they constructed actually with their hands, showing the tension between the individual rights and the collective rights of the community rights to health. And there were so many discussions around if the right to health means the right to infinite care, even care that damages health, which of course is not the case. So. Then the third presentation is a presentation from Uganda. The project is called Speech, and Ms. Christina Tulo is going to present it to you. Christina?
Good morning. My name is Tina Ntulo, and I am from Uganda. In the last 2 days, I have worked with participants from Costa Rica, Israel, South Africa, and the US to design a program that enhances the right to health for women of childbearing age. Mr. President, while there has been increased attention to women's health over the years, and women are reported to use health centers more than men, the prevalence of maternal mortality, breast and cervical cancer, and low contraceptive use, especially in developing countries, remains a concern. This implies a weakness in both health systems and community support for women's health, with disastrous results for food security, child health, education, and development as a whole. In solving this, we believe that if communities are empowered to work with their local governments and to put in place quality services for women, we should see reversing trends in maternal mortality, an increase in early detection and management of breast and cervical cancer, and an increase in contraceptive use. Of course, we keep in mind that prevention is always better than cure. In developing this concept, we plan to incorporate the new skills we have gained this week. For example, models of complex problem solving, systems thinking, enabling shared decision making, and my favorite, the use of games for behavior change. Other activities will include capacity building for planning, making information available on women's health, making it usable and accessible, and skilling communities to enable them to negotiate, persuade, and conduct their own self-advocacy. The program will also document and analyze process and result for lesson learning to identify what works, what is replicable, and what is scalable. We all know, and it has now become proven knowledge, that women's health is central to achieving the MDGs and in exercising the right to health for everyone. Thank you very much.
Thank you, Tina, very much. It is amazing how much this proposal became so detailed in a few hours. So they have it very clear. They even know that they would like to measure the results to be able to monitor progress, and they want very much to use tools to empower citizens to participate on the implementation, the planning, and the monitoring of these activities to improving maternal health. The fourth of our presentations, and the last before your reactions, it's from South Korea, and the project is called the Open Healthcare Information Bank. Ms. Yuri Kim is going to present it.
Good morning, good afternoon. My name is Kiri Kim, and I'm representing the South Korean team. I'm from the Graduate School of Science and Technology Policy from KAIST in South Korea. And over the last few days, I've been working with some of my colleagues from South Korea, from the Korean Ministry of Strategy and Finance, and a private consulting firm that specializes in healthcare, as well as a researcher from the KDI School of Public Policy. So the problem that we identified within the South Korean system is that information on medicine and healthcare is scattered and fragmented, hence creating a barrier to informed decision making. And this barrier at times can be even higher for less privileged populations. Our model stems from the belief that proper use of information is key to exercising one's right to health. With this as our background, we thought that there is a need for a system that could contribute to overcoming the asymmetry of information so that consumers of health can access information that is useful as well as reliable, which originates from different stakeholders. During this seminar, we discussed on the topic and came up with the concept of what we could potentially call the Open Healthcare Info Bank. And this should be a comprehensive platform for collecting, processing, and delivering information, which is verified in its amount and the contents and the quality. And it should have the objective of enabling informed and knowledgeable decision-making by the consumers. The administrative organization of this platform must be such that it is not monopolized by any one of the interest groups or the parties, and that the information must be available in a free and fair manner to all members of the society. We believe that the proper implementation of such a platform in South Korea will not only reduce medical and social costs, but it will also become a medium through which public engagement can be facilitated. This idea will be strongly reflected in our future endeavors when we return to Korea, and we will also love to explore the potential partnerships in the global arena in order to replicate this model overseas. Thank you.
Thank you very much, Yuri. So as you see, these were our 4 presentations. I mean, this one on open information, quite important. And I would like to pass to you, President Kim, for your reactions, questions, and thoughts for this audience. Back to you.
Thank you. Let me make just a few brief comments. I think it'll be especially helpful to hear from my 2 vice presidents, Sanjay Pradhan and Tamar. They're in many ways much more involved in the specifics of the work that we do here at the bank. Let me just say a couple of quick things, though. These issues are critical. I think the insight that governance has a tremendous influence on ability to provide basic services is an important one. An issue that's come up in several now presentations is transparency, accountability, the openness of information and data. And I just want you to know that over the past couple of years, my predecessor, President Robert Zellick, was a true visionary in this regard, and he pushed an openness agenda that we've now taken to many different levels. And you may know that all the data that we have at the World Bank is accessible to everyone in the outside world. And once you start down this path, you can't go backwards. And so I think the notion that governments need to be more transparent and accountable is critical. And I would, in fact, be very interested in hearing both Sanjay and Tamar telling us how the work's been advancing. Diagnostic tools to look at to assess the needs that balance population and individual needs. It's a very interesting idea, and again, we will have some comments on that. The issue of maternal mortality is an enormous one. And the area of focus that we have here at the bank is health systems. And I would say that the area where we're going to be most helpful is around sustainable health financing and health insurance systems, of which we know a lot about. And while we're less involved in specific disease-focused programs, we all know that maternal mortality is really a logistics and systems issue more than an individual medical treatment issue. And so we're very interested. We've committed to helping to tackle MDGs 4 and 5 very aggressively. And I think that there will be lots of other agencies and institutions that are going to be focused on specific aspects of the medical care. But I think we're going to have a very strong voice in terms of how to finance the kinds of systems that will actually eliminate maternal mortality. We think that that's something that's in our grasp. And the final note is that we're taking careful notes. Maria Luisa, of course, understands very in great depth what you've come up with. But I just want you to know that there is an enormous coming together of the global health community. And it's really, in many ways, serendipitous in that Margaret Chan of the World Health Organization is a very good friend of mine. In fact, I was part of the team that recruited her to come to the World Health Organization in 2003. Raj Shah of USAID is an old and close friend of mine. And there's so many people in the global health world that now are committed to coming together to take action in a way that will, we hope, eliminate any cross-institutional skirmishes and focus on what we need to get done at the country level. We're hosting, along with the World Health Organization, a group called the International Health Partnership Plus, and this will be in Africa in the near future. And we've made it really clear that issues like this, the proposals that you've presented, have to be presented to this group. And we have to sit down and say, okay, we know that these are important issues. These are legitimate, thoughtful proposals that have come from our member states. What are we going to do to make sure that these things get done? We're not going to compete with each other. We're not going to fight each other. We're going to just make sure that this gets done. And we've even taken this to a higher level in the sense that I've asked the Secretary General of the United Nations to ensure that every time we meet, and we meet every 6 months as heads of agencies, that we tackle a certain number of issues and insist that we have coordination and effective action across all these agencies. I remember a time when the heads of the global health agencies did not have a good relationship, did not have strong bonds, and when that happens, you have really, really difficult situations. I think we're in a different environment now, and all I can do is I can promise that when these meetings happen, we will make sure that these proposals are presented, and we will ask the question, why can't we do this, and why can't we do this sooner rather than later? Let me then stop and just ask maybe Tamar first to respond and give her perspective on these issues.
Great. Thank you very much, Jim, and very happy to have you here with us commanding the bank. And I promise we're going to be more malleable than your Dartmouth faculty. No, it's a pleasure to be here with you. I think Jim covered many of the issues that I wanted to touch upon, but let me just say how delighted I was to hear the 4 presentations. And in the span of less than 10 minutes, I think you touched upon all the important issues that need to be addressed to actually turn a right to health into a reality on the ground. So I was going to talk about the importance of accountability. You touched upon that, the importance of measurement, which is a critical ingredient to actually hold governments accountable, because we need to know what's happening on the ground and how much progress is being made. Information, overcoming the asymmetry of information, as one of the presenters mentioned, and your desire to develop diagnostic tools. Congratulations to you. I think you've covered a huge amount of ground in the 5 days that you've been together. Maybe let me just pick up 2 points in greater depth on accountability. I think absolutely right that this is critical. I would, I guess, invite you to think about accountability in a broad way. We know in a number of countries the courts have played an important role in ensuring that governments deliver on the promises that have been made, on the rights that have been enshrined in their constitutions. And I would say, that's possible in a few countries, but for the large number of countries, in particular poor countries with which we work, this is unlikely to be feasible and potentially even not desirable in terms of tying up a lot of resources in litigation. But there are other mechanisms for accountability. Certainly social accountability and the role of civil society in that is extremely important. But there's also accountability embedded in the relationships between governments and providers. And I believe you have a number of people in the room that have experience with this. I know the Minister of Health from Rwanda is there or will be there with you. And the work that has been done there on results-based financing, paying providers on the basis of services delivered on the ground, I would suggest is a very important vehicle for accountability that I think we need to leverage and take advantage of increasingly across countries. The second point would be on financing. I think we, as President Kim said, we embrace the right to health, but clearly the capability of governments to deliver on that right to health will be a function of their ability to generate resources and prioritize the right type of spending. So this is an important area in which the World Bank engages, and I think we have important contributions to continue to make here, to take a look at public spending as a whole in general, but also within the health sector, and provide the expertise that we have to highlight the kinds of services that indeed lead to better health outcomes. We do public expenditure reviews in most countries, and I think this is really important in terms of, as I said, looking at the allocation of resources from the perspective of equity across segments of the population, but also geographic areas. You also highlighted, I think, a segment of the population that has particular needs, but also is an enormous engine for growth and development. That's mothers and the emphasis on maternal health. And I certainly think that is extremely important. An unfinished agenda of the MDGs 2015, even by the year 2015, on which we need to continue making progress. Let me stop there and turn it over to Sanjay.
Thanks, Tamar. It's a real pleasure to be here. It's been a great pleasure to do this event jointly with Dartmouth, with the Salzburg Global Seminar, and with partners from so many countries. These were great presentations. They resonated very powerfully that what you're coming up with from a right to health approach resonates very strongly with the capacity development approach we've been pursuing. I'm not a health expert. Dr. Kim is and Tamar is. So let me just speak more from the point of view of the cross-cutting governance challenge that was referred to, which actually leads to the disconnect between the policy intent and the large amount of resources going into health and the actual delivery on the ground of health services. And when I think of what we have learned across countries and what it takes to achieve better outcomes of result, there are three elements that come through, and those three map very nicely with the presentations that have been made. The first element that comes through, which will lead to stronger delivery and better results, is more transparency and openness of data. So it's more disclosed to the public. And that was the presentation of South Korea that was made just now that stressed the importance of that open platform. What I wanted to share with you is that in the area of health, for instance, we are pursuing open data initiatives, both in the bank more generally, but in governments. And in Kenya, for instance, in the government of Kenya, we have helped to geocode all the health projects in Kenya and ensure that there are also health indicators with it. This kind of information helps empower the citizens on what the resources and delivery of services that they are entitled to. So that's the first area, which is transparency for citizen empowerment. The second area, which will lead to better results and better delivery, is in building the capacity of what I call the citizen sector to actually give feedback on whether services are being delivered. This capacity building side was again referred to in the presentations by Uganda and South Korea. And the one thing that we are working on and that we would happy to support initiatives going forward is the use of modern ICT tools, information communication technology tools, mobile phones, which can empower citizens to give feedback on whether they're actually receiving the services. The third area that can help achieve better results for the resources that are being put in healthcare is to have a multi-stakeholder approach to priority setting and to monitoring delivery. And this involves bringing together government and non-governmental stakeholders. In the area of health, for instance, we are working in Uruguay, Costa Rica to bring the Supreme Court justices, ministries of health, insurance funds, medical professionals, so that they can together set priorities. This is an area which was highlighted in the presentations of Egypt and Kenya. And I think that is really the frontier. How do you bring different stakeholders together to set priorities for the right to health that is being demanded at the individual level and then at the collective level? So just in summary, I just wanted to say these resonated very strongly from a governance perspective, both on the side of transparency, citizen participation, and multi-stakeholder approaches. And in the World Bank Institute, we would be very happy to continue to work with you in supporting you through these platforms. Let me stop there.
Yeah, and we have a few minutes, and so maybe we can take some questions from the audience.
That is fantastic, because I think that many people here would like to get all the knowledge that you have. And we saw so many experiences also of the work that you have been doing, or were doing before in Partners in Health, that were very enlightening for many of the issues here. And that, combined with the work that Sanjay explained that we are doing in WBI, many ideas came to the mind of many, and to mine as well. So I want to open the floor to people that would like to post a question. Or while you are thinking your questions, I would like to ask you, President Kim, I was really enlightened by the presentation by Jaime Bayona on the experience in Peru, and what exactly happened differently to bring this patient with TB that was told that she was actually go home and die. There is nothing to do for you because you have drug-resistant TB. And how they just put together all these different interventions and make it happen. So I was thinking, my question was, how could you scale up something like that? All this combination of activities to make really the delivery of healthcare something effective.
Well, that's a great story. And, actually the reason that it happened is in the room there with you. It was Dr. Bayona. And Dr. Bayona came to this. He's a medical doctor, but he didn't come to the problem from the perspective of being an infectious disease physician focusing on the treatment of individual patients. From the very beginning, what Dr. Bayona told us, and many of us were much more focused on treating the individual patients, what Dr. Bayona said is we've got to build into the project from the beginning this sense that we've got to, turn it into a full-fledged public health intervention, and then eventually we have to turn it over to the government of Peru. And that was the most extraordinary, I think, development, that we were able to first make the case that you need to treat these patients, because what we found was that the disease was spreading very rapidly in this community. And we first had to show that it's treatable. Then we had to show that it's treatable at relatively low cost by using community health workers. We had to show then that we could hand the treatment over mostly to nurses, but also to the Peruvian physicians. And then we had to show that the Peruvian government could take it over and scale it up to the entire country. Now, I know of very few examples still to this day where this has happened, and Peru did it well because I think it was built into the very design of the program. And the fact that Dr. Bayona does come from a public health background, but moreover, the fact that he thought about this from a systems perspective from the beginning, I think helped us enormously. And, to get to the issue of health financing, I hope he showed you that graph where it shows how much of the initial efforts were funded first by Partners in Health and then by the Gates Foundation, and then over time, it's gone completely over to being funded by the Ministry of Health of Peru. And I think the beauty in that particular project is that most projects don't think about sustainable financing. And in this case, we did think about it. Again, it was mostly Dr. Bayona, but we did think about it, and it happened at the end of the day, and they're very glad that they did it. But there's another example in Rwanda where, I remember in 2005 when we first started hearing about the Mutuelle program, where they were going to start a health insurance program. None of us believed that it would be possible. None of us really believed that in a country as poor as Rwanda, they'd be able to do it. But, with good government policy, focused on economic growth, that's been about 8% a year in Rwanda, they now have a functioning, sustainable health financing system. So health financing is not everything, but in the case of Peru, I think the lesson is really profound. You start from a disease focus, but you build into your thinking a systems approach from the very beginning. And then you understand what the steps are that are needed. And what we hope is that, right now, Africa, the average growth is 4.5%. We really believe that African countries are going to be able to have sustainable financing systems, but we got to think about how to put those in place now, as all this money for disease-specific programs are coming into place and have been churning. it's the economic growth in Peru that's the result of years, I would argue, of World Bank intervention, helping them to set the ground for economic growth that has allowed them now to support this program. So I would just say that, the right to health care is multifaceted. And it's not just always increasing the amount of donor money that's coming in. That's great. The donor money is needed, especially in the poorest countries. But you've got to think about the systems implications from the beginning.
Thank you very much. I will still continue thinking of that very enlightening experience from my systems background and try to merge the two, how to construct systems that are capable of scaling up experiences like that. I see one hand up. Could you please come to the podium for a question? Two hands. So.
President Kem, dear Vice Presidents, good morning to all of you. This is Ahmed from Egypt. Well, actually, in order to get and reach to the governance status we're aiming in our project, there are two other pillars which we didn't include in it, but we cannot reach that governance, especially in the turmoil of change that's happening there in Egypt now, without, number one, embarking on a real evidence of what is the best coverage for Egypt. Is it really the social health insurance which is the country is going through, or a universal health coverage? And I've read a very interesting World Bank paper. I don't remember when exactly it was, but it was actually one of the best papers I've ever read in comparison for the four coverage systems. But yet we need a lot of more clarification and guidance in this point. And I know that the World Bank has a lot of expertise in this point. This is the first pillar. The second pillar is, I think we can never reach this status of governance in the whole health system without embarking also on a DRG system. And I know that each country must have its own DRG system or guidelines. So you cannot import it, something that you cannot import it. So my question is, can the World Bank help in this? And what is your expertise about the best universal coverage system that suits Egypt, or how to reach the answer to this question? Thank you, sir.
Let me start and then hand it over to Tamar. I remember in the 1980s when the DRG, the Diagnosis-Related Group Approach, was floated in the United States, and the notion was that now that we have the DRGs and we know how much we're going to pay for certain interventions, all the problems in healthcare delivery will go away. Well, of course they didn't, and I think it outlines exactly the World Bank's approach. Right now, the developing countries are seeing lots of different funds for lots of different diseases coming in. And this is, I fought hard to raise that kind of money, and I fought hard to increase attention to those disease-specific problems. But if you look at the work that Dr. Bayona and I and others have done in Partners in Health, every part of our work has always been focused on trying to build those systems that can handle those diseases plus all the issues that we face in primary health care, and even extended to social protection mechanisms. And so what I would say is this. I think it's very important not to think, to not think that there is a quick solution to these problems, that somehow taking all these vertical programs that are coming in and then just tying a string around them is the equivalent of a functioning healthcare system. We found that actually doesn't really work, and that there are many things that you have to think of at once. Now, one of the things that we're taking to the International Health Partnership is this notion that please don't just advocate for your single disease programs. Those single disease programs are really important, but now that there's enough money, we've really got to think about what the system will look like. And I don't think that for Egypt there's any sort of, DRGs plus universal healthcare declarations will solve the problem. I think it's a much more fine-grained issue. When I was meeting with your president, I was very impressed that while he's a man of deep faith, he's also an engineer. And so part of our conversation was focused on how his engineering background could actually help him in thinking about certain social interventions. And I think you have that going for you. I think that what we need to do is to have a conversation around Egypt that really draws upon his personal experience and says, look, you have an opportunity now to build a system from the ground up. And you've got to think about things like finances, sustainability, and you've also got to insist that all this disease-specific money that's coming in will fit with the plan for the health system. Rwanda did that very effectively. I think Peru has also done that very effectively. But now, what we need to do as a World Bank and also the rest of the multilateral system is we've got to support countries to be able to make that argument that the money coming in has to fit with a robust and even inspiring plan to provide health care for everyone. Tamar?
Just quickly, little to add to this, and thank you for the question. I think you touched upon two critical elements of the design of a health system, the health financing mechanism and the provider payment mechanism. And I think my responses, which you alluded to in your comments and questions around DRGs, that there is no off-the-shelf system that will fit a particular country. So my response is to say we really need to work with you in Egypt to see what you have on the ground, what the priorities are of the leadership, and then hand in hand come up with a mechanism that fits Egypt's challenges, opportunities at the moment. I'm sorry, I don't know enough about the health system in Egypt to have an opinion on what that would look like at the moment, but these are areas in which we definitely engage with many countries, and we would be very happy to do the same in Egypt as long as we get a request from the government transmitted through the Ministry of Finance to our office there.
And unfortunately, I have to run, but let me end by thanking all the organizers of the conference. I've spoken already about the World Bank and Dartmouth, and I especially want to thank the Salzburg seminar. I mean, I think that the partnership that was created when I was still at Dartmouth is been wonderful for Dartmouth, I know, and also for the World Bank. And so I want to thank you for spending the kind of time you spent in tackling these issues. And I want to thank you also for inviting us to participate. Now, I don't know if you guys can stay longer, but I unfortunately have to run to another event. Thank you very much.
Thank you very much.
Lisa, I think there was one other question, and Sanjay and I would be happy to stay and share that question.
Very well.
Hi, good morning. I'm Manu Devar. I'm an attorney at Arnold & Porter in the U.S. My group, led by Kenya, was dealing with this issue about diagnostics for testing the health of healthcare delivery systems. And I was wondering whether the World Bank has developed or follows any universal metrics for diagnosing healthcare delivery systems, particularly when you're looking at such diverse social and political and cultural facts in countries, like China, Sudan, UK, Norway. How do you come up with some sort of common themes and common metrics? Thank you.
Maybe I can, because I love this topic, and I can bring from WBI. This has been such a debate for many, many years in the bank. How would you be able to look into health systems and analyze health systems in a structured way that you can get indicators that are comparable across countries? So we use in the capacity development at WBI for the last 15 years, let's say, we have developed with many partners in the world a framework to analyze health systems that looks mostly into the causes of the problems and diagnoses the causes of problems that doesn't allow a system to get to specific goals. And based on that, then there is a definition of the indicators to measure the outcomes. But it's not a perfect science. It's never a perfect science. And I think that there's so many other indicators that have been also developed in the area of governance, and that Sanjay could explain a little more about that how to measure issues of governance, transparency, and accountability in systems. Sanjay.
No, actually, Tamar, why don't you?
Well, very quickly, actually, Maria Luisa is much more of an expert in this than I am. I really am not from the health sector, but to say that has been, it's a very good question, because I've asked my health colleagues that question. How do I know a good system when I see one, a good health system? What are the ingredients of what makes a good health system? And as Maria Luisa mentioned, this has been discussed within the global health community for some time. And one of the features I have found in the global health community is that it's very difficult for them to come together with a consensus view on difficult challenges. In part, that's a reflection of the complexity of really health systems and healthcare delivery. So typically, we look at health outcomes as the primary indicator of whether or not health systems are delivering. But as many of you know, there's a lot that goes into health outcomes beyond the health system itself. So we are at the moment, Maria Luisa talked about the diagnostic tool WBI uses, but we're also in the process of now looking at developing this tool on universal coverage. So I hope to be able to have a fuller response in about a year or so when we have fully developed that diagnostic tool. Thanks.
Okay, just a quick word. We don't have, governance is such a big term applied to any particular sector like healthcare delivery. You would need to develop an indicator from a governance perspective of what would be the indicators to assess the governance health of that system. There isn't one right now which is off the shelf that you could use, but some of the components would be around, if it's on a public health delivery system, it would be around, the components would be the government capacity and transparency type of indicator. For that, there would be some way of assessing the degree to citizen involvement and the capacity of non-governmental actors to oversee. And you would need some indicator of the extent to which you have multi-stakeholder consensus around that. That's just all I can say in general terms. It would actually need to be applied to a particular sector in that sense.
Thank you, Sanjay, Tamar. So let me know if you want more questions, or otherwise I wanted to introduce someone that has a very profound quote that make me think that this is the best way to approach this challenge of, making systems that could really realize the right to health progressively. A very enlightening person. So here with you, Albert Moulet.
Thank you very much, Maria Luisa. And thank you very much, Vice Presidents Pradhan and Tink. It's been an incredible session here from Salzburg and perspective here. If you could see the people in the room, there's a great deal of gratitude for you and President Kim taking the time to be with us. I also want to thank all of you. Certainly, a tremendous amount of work was done over the last 5 days. And when we really had our sleeves rolled up over the last 2 days, it wasn't always easy. In fact, there was a good bit of frustration and a good bit of forming and storming, and the products were obviously well worth that effort. And I want to thank all of you, including the 4 groups who were so well represented by Dr. Maha and by Anne and Tina and Kiuri. And given that we were working so closely in such small groups, I just want to draw attention to the fact that the first Salzburg seminar was 65 years ago. And it was chaired by Margaret Mead, perhaps the person who taught the world at a formative time for the science of anthropology the importance of taking a scientific approach to studying the importance of culture and context in the way we construct meaning in our lives. And Margaret Mead is famous for many things, but one of my favorite is the oft-used quote when she said, and remember how hard we worked in small groups, "Some people doubt that a small group of committed people can change the world, when in fact nothing else ever has." So thank you to all of you for your hard work, and again, thank you to you in Washington. It's been wonderful that you could join us.
Thank you. That was wonderful.
Thank you very much. Thanks for sharing with us. And there will be many more ideas, things to share next year, maybe. So, bye-bye. Thank you.